Hello everyone, welcome to the 27 Degree with Chris and Nancy from 27 Degrees Consulting. And today we're really delighted to have Wendy Morrow with us. Wendy is a nurse practitioner who is part of a nurse practitioner home care program, a program for home care, homebound patients. I want to talk a lot about that. It really is a great service to the community. But before we do, Wendy, thank you so much.
Thank you for having me.
I want to hear a little bit about you and what your background is.
Sure. I'm a family nurse practitioner employed with Prima CARE, home care division. Prior to that, I was a registered nurse for 22 years, and I did a variety of nursing jobs when I was an RN. I spent the last 10 years in a physician clinic assisting with COPD patients, and the patients used to always call and say, "Oh, I'd like to see Wendy. I'd like to see Wendy in the office." So that prompted me to go back to school. For my NP certificate, so so I could help some of these patients, and it's been a great decision. It's been the best thing I ever did.
That's great. Well, thank you. Before we get going, I want to hear a lot about this program, but I just want to mention our sponsor, of course, Bay Coast Bank. Thank you for sponsoring us. We appreciate it. Bay Coast Bank is just right for all of your financial needs. Visit baycoastbank.com or call 508-678-7641. So Wendy, tell us a little bit about the program. I mean, it's interesting. I mean, there's, as a physician, I see a lot of patients who have trouble getting out of getting into the office. So, I mean, there's obviously a need for this. And we have a number of patients who are really debilitated and due to medical illness can't get to their visits. Tell me a little bit about what you do and about, what kind of patients you see and all that.
So we see a variety of patients. We have some young patients with chronic diseases that we see, all the way up to elderly people in their hundreds. I always say I have a small group of patients in the city, and that's my 100 club. So we enjoy seeing the elderly patients. Homebound criteria, it varies so vastly because people can get around, they can walk around, but if they're in the third floor apartment, those flights of stairs, they just can't do so. They may be mobile, but the stairs are an issue, and especially in the city of Fall River with the tenements.
Yeah, there's a lot of tenements, right?
Yes, so a lot of people are shut in because of their living environments. And a lot of people have been in those apartments their entire life, and they don't want to consider moving, and I totally understand that that's their home. So, I'm sorry, go ahead.
No. It's amazing, though. We don't really think when patients come to our offices how much they go through to get there.
To get there, right. And even transportation, if they can get down the stairs and get there, getting in and out of a car is another challenge. So depending on their mobility, we see a lot of COPD patients who just don't have the stamina.
Yeah, because of their breathing issues.
Their breathing issues, yes.
Right.
Yes.
What's the oldest patient you have?
The oldest one I have right now is actually a man in the town of Swansea, and I believe he's 103. So I did have a 105-year-old woman in Somerset, but she has since left us. But I do have several women over 100 in the city, yes.
And the youngest you have?
The youngest I have, I'm going to say 32.
Wow, really broad range.
Yep, 32 years old.
Mostly older folks.
Mostly older, elderly folks that we follow, yes. Yeah. Yes, for sure.
So Wendy, you talked about seeing patients in Fall River and then Swansea, Somerset. What's your, how far out do you travel?
So we have one nurse practitioner that travels to Acushnet, New Bedford, Fairhaven, Westport, Dartmouth. And then I cover Fall River, Somerset, Swansea, Seekonk, Dighton, Rehoboth.
And then there's some Rhode Island coverage, too.
There is. We've got a nurse practitioner who does cover Tiverton, Little Compton, the Rhode Island patients for us.
So when you go out to see patients, is this for their annual? Is it like sick visits?
We do Medicare wellness visits.
Okay.
So we have been focusing on quality measures and trying to get all of our Medicare wellness visits done. We see sick patients.
Preventative type care.
Preventative care.
Health maintenance. Okay.
Yes. We do lots of sick visits.
Yeah.
Lots and lots of sick visits. So we get referrals in from the primary care doctors. Somebody called in, they've got these symptoms. Can one of the nurse practitioners go out and treat them? So we do a lot of sick visits. And we also do hospital follow-ups. So we have a great relationship with St. Anne's Hospital.
Nice.
So when they've got somebody in their setting who they think would benefit from a home visit, they send us a message, and then we follow up with them.
Now, what happens if someone's mobility is impacted like short term, they broke a leg or they're going through an acute phase of a disease. Do you see patients in that scenario too?
Yes, we do. So we follow them on a short-term basis if needed
Yeah.
while they're recovering from their acute injury, illness, and then we release them back to the primary care provider once they're back to baseline.
So this home care program, it's not like a typical VNA setup. This is for providers to go out into the home to see patients.
That is correct. That is
Do
correct.
they have to meet a stricter criteria than like a normal home care? Like what makes a patient eligible for this program?
They're eligible if they have difficulty leaving the home, if they have missed multiple appointments with their primary care doctor, so there's been a lapse in coverage due to their immobility or their chronic diseases, then we will go out and see them.
But the criteria for like seeing the patient in the home is really the same as they just have to have a medical diagnosis that supports the medical interaction and then be homebound. So I know with the VNA, I know what you're mentioning with the VNA, there's very strict criteria about certain diagnoses and this and that.
Right.
I guess similarly, when we see someone in the office or at home, they have to have a diagnosis that meets the need.
Right.
But all of these patients have diagnoses that meet
Absolutely.
the need, so it's not really an issue.
Does insurance come into play at all? Or do most insurances cover once a need is established?
We have not had any issues with insurance coverages at
great.
all. Yes, no issues whatsoever.
Chris, as a primary care physician, like what's the process for you to refer someone over to Wendy? And like how quick then do you get to see them?
So it's pretty simple. There's a phone number that is the home care office that our staff will say, refer Mrs. Jones for a home visit with, the home care nurse
Right.
practitioner program. They'll call the secretary or send a message by the computer, and it just gets done. It's pretty quick, actually.
It's
I
very
mean, for sick visits, usually you can get there, within the next day very often.
Absolutely. And if it's an urgent call, we always are able to accommodate them. We move people around, and we're always able to accommodate a sick call.
Oh, that's
Absolutely.
nice. That's great. So then when you're in the home, how long do your visits typically last? Like, are you under the same kind of time constraint that you are when you see patients in the office? Oh,
No,
you're
I'm
smiling.
not. I'm not, and that's one of the best things about this job. You can go in, you can sit down, you can talk to the patient. Many times they're elderly, so they live with other family members. So you've got the whole family involved. So you get a broader picture as to what their needs are and what is going on.
So you're picking up on a great dynamic because you're seeing a whole piece of the puzzle that you just don't have the advantage of seeing in the office.
Absolutely.
So
I
you can
always-
fit like a lot of little puzzle pieces together.
Absolutely. I always say when the patient comes into the office, they're typically at their best, they're dressed, they're
Right.
clean, and then when you go into the home and you see like, oh my goodness, this is where the patient
Right.
is living, it's definitely an eye-opener.
I remember, when I used to do home visits, and I don't do them anymore because it's somewhat impractical for me to do
Yeah,
it with the office
sure.
as it is. But I do remember you did gain a lot of information that you would never get from them just coming into the office. I mean, you get a sense of, how they live. Are they clean? Are they not? How do they cook? What kind of food are they eating? All things like that you're not going to pick up otherwise. I think I just want to point out it's such a great service because this isn't really like a money-making service.
Absolutely.
It's really hard to actually break even with these types of programs. That's why a lot of physicians have stopped going to homes. It's just too time-consuming. But PrimaCARE believed that this was an important program for the community, so they support it fully, despite the fact that it's not really a program that may even break even. But it adds so much value to the community and prevention of hospitalizations and just improvement in the health of our members in PrimaCARE, our patients, that they've been just incredibly supportive of it, even though.
So then when you go out to the home, like say you get a referral from Chris, please see this patient for XYZ. What's your follow-up back with Chris? Like, how do you know how the visit went?
Well, we share the same database, right? It's in the computer. You may want to mention this, but I'm kind of jumping in here and giving you all and answering the question, even though you're supposed to be the one interviewing. But we share the same database, so all the information's there. So if Wendy sees Mrs. Jones, I know what happened because the visit is in the computer. But if there's something critical, then we have a secure texting format that Wendy can send me information on, or she can send me a message on our electronic medical record, which is eClinical works. So there's multiple ways to really communicate as issues come up.
So when you see someone in the home and you're like, oh man, you need a little bit more than just me here for support, what are your next steps? Like, can you bring other services into the home, like PT or?
Yes. So we always, if there's a need, we always consult the visiting nurse agency of their choice. And I work very closely with Accent Care
Yep.
in Fall River. We have a great relationship with them. I know all the nurses. They know me. They have my cell phone number. So it's a very, very streamlined way of communicating. PT, OT, speech can go out into the home visiting nurses. A lot of times if I'm seeing somebody for wound care, I can increase the visit times.
Nice.
Because a lot of times it's a standard twice a week,
Right.
4 weeks, 6 weeks. But I have the ability to increase if I see that there's a need to increase services. So yes, we work with the visiting
You
nurses.
mean increase the visits with the Visiting Nurse
Yes.
Association?
Yes, yeah. A lot of times we come into that. It's a standard,
Yeah.
how they write
Right,
the orders,
right.
and so yeah, I'm able to do that, and definitely keep the lines of communication open. So
And that's important for our viewers to understand. These are really complementary services. So you have the Visiting Nurse Association, which is our nurses. They'll come in, they'll do med checks, wound checks, but they're not providers, meaning they're not nurse practitioners or
Correct.
physicians. So a nurse practitioner is clearly at a different level of education, and it allows a different set of eyes and a different view on
Absolutely.
what's going on with the patient.
So then are you the ordering provider as when like the other services go in? If I'm a visiting nurse, which I kind of am, and you go into those and like and I go into the home, am I just dealing with you or am I reverting back to Chris for the orders?
nope, they deal with me completely.
That's so nice.
Yes,
It
they-
just
they
keeps it
deal
so
with me.
clean. Not that you're not nice
No,
to
I
deal
know.
with.
But even
But
like
it-
medication refills.
Right,
Yeah.
right.
So Wendy almost becomes, for some of these patients, not all, but you become the primary.
I do,
right?
yes.
Because so what ends up happening is the patients are unable to come into the office anymore. So you kind of lose touch with them as a physician. Wendy's in there regularly. So over time, she may assume a lot of the responsibilities that the physician would have had and really become almost like the primary. And we'll be the primary there still. We're still there for questions. Some patients still come into the office if they can, they'll get themselves in once every year or two.
Yes.
Sometimes they just can't, and physicians have a different sense of how much involvement they want with someone that they're unable to see. So there are some physicians who will remain involved, and there are some physicians who kind of pass everything off, and it's really
Yes.
up to the physician and the patient.
Well, what's nice from a nursing perspective is I would love dealing with one provider, and then you establish a relationship with them, you get trust involved in that relationship, and then it's just like a nice, neat little circle. You really get to know each other and depend on each other.
It is, and like I said, from being in the community for the past few years, the nurses know me.
Yeah.
The therapists know me.
Right.
So it is. It's a nice working
Yeah,
program.
the
right now.
conversations
Yes.
take on a little bit of a different tone because you're all on the same page.
Or if I show up to a home and there's a therapist there, they, I'm so glad you're here. I don't have to call the office.
Right.
I can, can I get your
Yeah.
verbal here? So it works out very well.
That's great. So now we've talked about the nurses, PT, OT. And the nurses will bring in home health aides if they qualify. Lab drawers, can they get their lab drawn at home?
Yes. So we absolutely can draw labs at home. We can do ultrasound. We can do X-ray in the home as well.
No, son.
Yes. Yes, we
Yeah,
can.
you can get portable X-ray.
Yep. And ultrasounds now too. So it's
Pretty snazzy program.
we're trying to cover
Those
all the
are,
bases.
and
yes.
Those are other companies that we basically
Yes.
are working with.
Contracted with, but yes, we work very well with them, and so the patients do not have to struggle to get down the stairs, into the car, on a table somewhere, and in an X-ray or ultrasound. Everything's done right in their home.
How long has this program been going on, and what were the origins of the program? Like, who thought of this?
It was started before I started with PrimaCARE, so Dr. Joncas can answer that question. I don't know how long ago it was started.
I mean,
Yeah,
it's
it was kind of a natural development. We had a nursing home program that Terry Ferreira nurse practitioner who works with me, I've worked with many years, and myself started, and we were in the Stewart system.
Right.
And then we came to PrimaCARE, and we brought the program over there to PrimaCARE. And then there was this natural progression to, think of a home care program. I think Terry was the one who actually probably came up
Yeah.
with it. And then, it was the piece that was missing, because we had the nursing home, we had the office, and then there was a lot of these patients who were in between who weren't nursing home patients. They couldn't get to the office. We wanted to be able to take care of them, and that's really how it all came to fruition.
Wendy, when you're in the home, some families really struggle with, is my parent safe in the home? And what's that turning point where you really have to think about assisted living or nursing home care? What are some of the red flags that you see that you're like, this discussion may be on the table at this point?
So when I do the medication review, I'm looking at the medication bottles. And when you see the date, it had been refilled, say, 3 or 4 months prior. So that's telling me that they're not taking the medications properly. Something else is falls. I'm getting calls, patient has had a fall, patient had a fall, patient's in the ER. So those are some of the red flags that I see. Also, when you go in and, if the patient is not kept, not clean, not changing their clothes, the house is in disarray, those are other signs that we need to have a discussion with the family.
Sure. Now, when you're in the home, I know for myself, like, there's all patients along the spectrum of how organized they are and what are like kind of best practices for families to incorporate when they're looking in on an elderly parent, for example. So some of the things would be like having the med list posted on the fridge. Like, can you share some of those like nice kind of tips and
Sure.
that make it maybe easier for you, or in a crisis situation you can just kind of grab stuff and go?
Sure. I mean, the med list on the refrigerator is great, and a lot of patients who, if they've got somebody coming in to fill their med planners, the nurses will put that up there for us. The MOST form. The MOST form is...
What is that?
The MOST is the form that identifies what their wishes are, if they want to be resuscitated, if they want a feeding tube, if they want CPR, BiPAP, CPAP, all of their...
Dialysis.
Yeah, dialysis.
All that.
So that's very important, because when 911 is called, those EMTs need to know what the patient's wishes are.
Where should that be kept? Is there like a standard place?
So I always recommend either on the refrigerator or right above the bed.
And how do families get that form?
So they can get it from the doctor's office. They can get it from the physician. They can get it from us at the home care program. The visiting nurses also have them on hand.
I know I used to download a form, the 5 wishes. Is that still something that is in use?
It's not something that we really use anymore.
No, it's an
out
older
there.
version.
You still see people who go to their lawyers and come back with forms that are similar to that, but really, you don't have to spend money. I'm sorry to my legal friends out there, my lawyer friends, but you don't have to really spend money doing that stuff. I mean, it's good to get, obviously, estate planning and all that. It's a whole different topic. But as far as like the 2 main forms, which are healthcare proxy forms and MOST forms.
And that's MOLST.
Massachusetts Orders for Life-Sustaining Treatment. Every state, pretty much, I think every state in the union at this point has this form available. It may be called, if it's in Oregon, it's called something else. In Rhode Island, it's something else. Every state has it. And these are actually medical orders. I'm going to digress a little bit and talk about the difference
No, I
between
think it's
a healthcare
important.
proxy and a MOST, because I think this is important to understand. So the MOST are medical orders. So these are orders that if an EMT or a paramedic or anyone came to the house in an emergency situation, they would look at this and they would take these as medical orders, such as the same as if someone was in the hospital, okay? They go to the ER, they're medical orders. And it goes over, as was mentioned, what would you want in the case of cardiac arrest? Would you want CPR? Would you want intubation? Would you want to be on a ventilator? All that stuff. It doesn't require a healthcare proxy to make a decision, okay? Because sometimes a healthcare proxy is not available. Now, a healthcare proxy is a different situation. These are not medical orders. A healthcare proxy is a legal form. It basically allows someone to make a substitute judgment for the patient if the patient cannot make decisions on their own. So right now you can make decisions on your own, but if you were in a terrible car accident, you had a head injury and were unconscious, we would decide what to do based on one of two things. If you had a MOST form in place, we could immediately follow what your wishes were. If you did not, and you had a healthcare proxy, we would have to contact the healthcare proxy, and then they would make decisions. The healthcare proxy actually will trump a MOST form. So, meaning, we will follow the MOST form, but if a healthcare proxy comes forward and says, yes, this is on the MOST, however, I've had other conversations with the patient, and I know what they really would have wanted, and they would have wanted X, which is different from Y, then we would follow what the healthcare proxy wanted, unless it just seems so odd and unusual, and then that brings up like a whole ethics committee and a whole other legal set of issues. But generally, these are two different forms. One's a medical form, one's a legal form. The MOST you can follow immediately: paramedics, ER personnel, doctors in the hospital. The healthcare proxy requires a living body to give guidelines and tell us what they want. So it's a little bit more bulky. You should have both. They're both important for different reasons, right? I mean, the MOST gets you going, but these decisions are very complicated. You need to often have a whole conversation as things evolve, and that's where a person comes into place. A piece of paper isn't necessarily going to give us all the information we need in very complex situations, but it'll get us started.
Right.
And then the healthcare proxy kind of takes over.
Now imagine the MOST, and again for our viewers, that's MOLST.
Yes.
The MOST forms are available online, and we'll make sure we get some type of link and post that on our social media
they are
sites.
available, and we download them from the office from online. We just go to mass.gov,
Right.
but we have them in the office or in every patient room.
Do they have to be signed if they're like orders? Do they have to be
Right.
signed by your
So
physician?
this is the other difference. So a healthcare proxy does not need to be signed by a physician or a practitioner of any sort. It's signed by the person who is making the decision, and it's also signed by the person who is the healthcare proxy, and that's more so that they know that they are a healthcare proxy, because there's lots of situations that come up where someone appoints someone healthcare proxy and really doesn't talk to them about what they want, doesn't even let them know they're the healthcare proxy. Well, that's not really useful. If that person doesn't know that they're the healthcare proxy and what that person wants, they can't really make decisions. So there's two places to sign. There's one for the person who is the person who wants a healthcare proxy,
Right.
and the one who's a healthcare proxy. The MOST has to be signed by a practitioner. These are medical orders. So just like when you're in the hospital, we sign a chart. We'll sign orders, give potassium or draw labs or whatever it may be. It has to be signed by a practitioner, or it's not viable.
And just for everyone that's out there too, you don't always have to have your spouse as the healthcare agent. You have whoever
You may not
is
want to have your spouse as the
comfortable.
healthcare
Well, John isn't mine, and don't laugh about this. I know I always tell stories behind John's back about John.
Depending on your
But
relationship,
well, no, but he had mentioned to me one day that he would never be able to take me off of life support.
Well, yeah, I say it jokingly, but that's a whole issue. If a spouse feels they can't make decisions that you would want them
he would
to
say
make,
he would really struggle doing that.
Then you have to pick someone else. You can't
Right.
assume that your spouse is going to make appropriate decisions. You have to have that conversation with whoever's going to be the healthcare proxy. This is what I want. Would you be able to do this? And if they say no, then you really have to move on to someone else.
Right. Which Billy's going to pull the plug for me. Thank you, Billy.
I'll do it for you. Just
Hey,
do the healthcare proxy.
No, that's not nice. So, and talking, Wendy, when you're involving families in these discussions, I mean, this is an uncomfortable conversation for some families to have with whoever, if it's a spouse or a parent. So do you ever facilitate some of these conversations, and can you give us a glimpse of what that
Sure.
conversation is like?
Sure, we always discuss code status, especially with the elderly population. So we go through what each of the items on the MOST form means. Many times the family members are not able to make a decision at that time, so I leave the form. They can discuss, they can have a meeting, they can speak to the patient as well, of course, and then we circle back again and we discuss what their wishes are, and then we sign the MOST form. And a lot of times it's not done the same day. Families need time to
Right.
digest
It's all
the
moving parts.
information.
Exactly.
Yeah, they need
You know, one interesting
time.
thing is, although it's a difficult conversation, what's much more difficult is someone ends up in a crisis and no one knows what to do.
Right.
That's a
Exactly.
much more difficult
Absolutely.
conversation. So as hard as this is, I would really recommend if you have, you know, a loved one out there who's getting to a certain age or health status where these issues may come up, don't wait till you're in a crisis, because that is a much more difficult situation than going over a form and trying to figure out what you might want in this situation.
I think it's just a gift that you can give to your family too, so they don't have to have this big, heavy decision on their
Right.
shoulders. You know, if
Sure.
you have those conversations, you know, I have a death file that I update and send to my kids every year.
Yeah, that's weird, but
What does that mean, a death file?
A death file. So, I make. We have a financial piece of that. We have what happens if we get into a car accident, my husband and I. And then we just have some safekeeping things. And we email the kids. We have 3 kids. We email the kids a file every year just saying, as you know, these are my wishes. If I can't make my healthcare decisions, for me personally, I don't want to be kept on event. I don't want to have that done. I don't want a tube feeding under any circumstances. Those are my.
Get remarried to, you know, that was.
I told him I'd haunt the hell out of him. But all that, and we have these forms, and we send them updated or just mail them the forms that are still in place, because these forms don't have an expiration date on them. I don't know about the most though. Do you have to re-sign that every so often, or is that good forever?
No, it's good forever.
But
Great.
you can void it out and change it at any
Yes.
time. So,
Yes.
And copies are legal, so you know
Yeah.
you can do it. Make a copy, give a copy to your physician, give a copy to the hospital if you're hospitalized. Always keep the original.
And that's a good point, because many family members hand the EMTs the original,
And they never-
and then they never get it back. So it's a very good point that they should make copies
Yeah.
and hand out the copies, not the original.
And then
Yeah.
if you change your mind and you want to do something different, you just scratch it out, put void, and do a new one, and that's it.
Yeah.
It's easy.
Yeah, so we just every year we just update the kids with all our information, and we have an online service that keeps all our passwords and everything, and you can have a certain amount of access given to the kids for all that stuff too. So as they look at your bank accounts and all this and try to figure out post death what's going on, they have access to everything that they need to make
I
it
mean,
a
I
little
joke
bit
around
easier.
that you know, it's a little bit morbid, but it really is actually not. It's very
Yeah. Well, you know what you
very
don't know though?
forward-thinking.
We already have our funeral clothes packed up in the closet for them too, so they just
Okay.
have to go and grab a
That
hanger.
might be going a little too far.
Oh my
but-
goodness.
I just know, like when my mom died recently, and can I tell you, it was so nice just to
Yeah.
go in her closet and grab a hanger that had everything there, and you don't have to go fishing for things that you don't know.
Nancy's ready to move on to the other realm. obviously.
I just want to make it as easy for
Easy.
the people that aren't going with me.
I think it's very, very kind of you.
But
it's
they don't need to look at all to think during this situation.
yeah,
so I
it's
want to
hard
make it
think
as
during that situation.
thoughtless
Exactly.
as possible.
So,
I
yeah,
guess.
but you know, tell me a little bit, if we can move on to a different topic, if you don't mind. Tell me a little bit about the relationship with the hospitals, because I think there's some interesting points we can discuss here. And the main point that I want our viewers to know is that, contrary to popular belief, hospitals actually don't want patients to get readmitted,
Absolutely.
because this is something probably
That's
a
a
lot
great
of folks
point.
don't know. But hospitals get paid in a number of ways. They get paid when a patient is hospitalized, certainly, but they also get paid by keeping patients out of the hospital in many situations.
Correct.
So you have a very strong relationship with St. Anne's and actively work with high-risk patients to try to keep them out. Maybe you can talk a little
Sure.
bit about that.
Sure. So I have a great relationship with the case management department at St. Anne's Hospital. We are in communication every single day of the week. So when they have a patient that they feel meets the criteria for the home care program, they will message me. Oftentimes, I will go into St. Anne's Hospital, meet the patient, give them the information regarding the home care department, and then circle back when they're discharged and see them in the home. So we work very closely on high-risk patients. We want to keep them in the community and not back in the emergency room. So when you make that initial connection, we give them the home care card, and we always, and VNAs do this as well. If you're having a problem, you're having an issue, please call us. it may be something that we can handle in the home as opposed to going into the emergency room. So we work very closely in trying to keep people in
I
their
think
homes.
that's great because sometimes you're looking at 5-6 hour waits when you go into the emergency room as well, and no one likes to.
No, and sometimes it's, the dressing fell off, or,
Right.
I dropped my medicine here, or very, very
Something that would take 20 minutes.
20 minutes to take care of.
Right.
Yeah.
Now, I should just reiterate, this is a program for patients that are PrimaCARE patients, and
Yes.
I'm unsure if this program exists in any other systems, but right now, it's a wonderful program that PrimaCARE supports and puts out there.
Right now, it's a PrimaCARE program. I mean,
Yes.
there probably are other similar programs in other systems that are out there. You'd have to ask your primary care doctor to see if that were the case, and they would be able to tell you. But if you do have a primary care physician, then you can access this program.
Yes.
What about transport, like patients that have problems getting into the office before they might look at a home care program? Does PrimaCARE do anything with transportation of patients? I know that had been talked
they-
about here and there.
They were doing transportation, and I'm not really sure if that's still active now. I
No,
think that
it's
program
not.
stopped,
Prior
didn't it?
prior to COVID.
Yeah,
Right.
I
It was
was
very
right.
active,
They were
yes.
doing it
Right.
prior to COVID, and then it became unsafe during the
Yeah.
COVID time,
Right.
so it was ceased, unfortunately.
But depending on the patient's insurance, many of the insurance companies will provide transportation for them.
And is that like the Council on Aging vans that you see around?
Not only that, some of the Mass
provide.
Health, Senior Whole Health, Navicare, the Fallon system. So they just need 3 days notice to set up the ride, but the patient does have to be able to get out to
good to know,
the
too.
curb, to the sidewalk.
Some of your patients can't even get up
No.
to the curb, so that's, they're not even really able to use that type
No.
of program.
No.
So with now that you said the word COVID, I'm going to ask a follow-up question. If rates should spike again going into the winter, how did that impact you seeing patients in the home, or did it?
It did not impact us seeing patients at all. We continued to work home care throughout the entire COVID pandemic.
Wow,
We never stopped.
that's great.
Yep.
Now, Wendy, do you have a patient story that you can share with us, like a little?
Any identifying information, of course.
Yes,
Something that
yes.
you feel the program really impacted on someone.
Oh my goodness.
There's probably lots.
There's lots of them. I'm thinking about. So I have a 101-year-old woman, and if Terry's watching, she knows who I'm talking about. She's my favorite. She has been homebound. I've been seeing her for 4 years, so she probably has not left the home in 6 or 7 years. So she had not seen her primary care doctor prior to me going out. And it came to the point where the primary care doctor felt uncomfortable refilling the medication, so that's how I was involved. So we have been keeping her up to date with all of her preventative health maintenance, labs, immunizations, getting services in the home for her, Bristol Elders, a home health aide, physical therapy when she needed physical therapy. Her son has my cell phone number, so he calls me. I was at the house on Saturday. Mom didn't seem to be right. Can you go out and check her out? Out there on Monday, treating her for acute UTI.
Great service.
So I feel that we have kept her safe, well, in her home. Whereas suppose she had basically fallen off, the provider's radar because she couldn't get out.
Right.
So we have kept her, we've kept her home and healthy.
Isn't that so important to the patients too, to stay in their home if they
Yeah,
can?
I mean, before this program, patients like that, how would they access the healthcare system? It would basically be by 911.
Right.
They would stay
Right.
at home until they declined to the point that they required an emergency room visit. They'd call 911, they'd go, they'd probably be hospitalized, they'd come home. Once again, they decline over a period of time, and it became a kind of a vicious cycle over and over. So with the program, we're able to impact on that and and stop that cycle.
That's a huge impact, because especially with the elderly population, they decompensate so quickly. And if you can go in there and nip problems in the bud, and then they get to stay
Yes.
in their home, they get to stay at a healthier level, and
Absolutely.
they're just happier, and they maintain a certain level of independence. So
Absolutely.
And I
So,
think some of the early hospitalization data show that there's been a positive impact on the reduction of hospitalizations.
there has
absolutely.
to be.
Yes.
Yeah.
Yes.
Yeah.
So, it really does. I mean, there's a lot of reasons not to be in the hospital, of course.
Of course.
Beyond the fact that there's, there are infections or drug bacteria that are resistant to a number of antibiotics. It's the cost. It's patients often decline in the hospital, and it takes a long time, if ever, for them to get back to their prior state of function.
Right.
They lay in a bed, they get weak, et cetera, et cetera, leads to rehab stays. There's lots of things that can happen. So we want to prevent those as best we can.
Yeah, this is a great
And
service.
none of these elderly people want to go to the emergency room.
No.
They
Right.
don't want to go and sit, for an
Of
extended
course.
period of time. So this, they're very, very grateful and happy with the service that we can take care of,
I'm sure.
small issues.
Yeah, I mean, if you're 95 years old and, you have a certain life expectancy left, and the last thing you want to do is spend a lot of that in a hospital.
Absolutely.
If you can stay home, where you're
Home,
comfortable.
in your home.
Well, what's
Great.
nice too is like a lot of patients get so anxious going into a doctor's office too. Here they're in their home, they're relaxed, they can think. When you're talking to them, they process things differently.
Yep. So I always talk about blood pressures.
Yeah.
White coat syndrome. We've got all these patients. I go back out and say, "Do you see so and so for a blood pressure check? Their blood pressure was, this." They're in their own home. They're not rushing to get out. They're comfortable. Their blood pressures are normal at that.
you're getting like a true
I'm
reading.
getting true readings.
Yes.
Yeah, I always say the blood pressures are fantastic in the home because they're not rushing to go
Right.
anywhere. They're not nervous.
Right.
They're not sitting in an exam room waiting to be seen.
Right, and then on the other hand, we have people who come into the office and their blood pressures are high, and we treat them, and they were probably over-treating in some instances because they're anxious, and then, the next call you get 2 weeks down the road, they passed out.
Yeah.
So, yeah, I mean, these are legitimate concerns.
Yes,
So,
absolutely.
Yeah.
I just love the fact that you offer this service. I think it's just sweet,
It really is the best service in the city of Fall River. It really is.
Yeah, we
I
love
mean,
it. That's great.
it's fantastic.
I mean, it was this whole niche that was missing, I mean,
Yes.
we have the nursing home program, we have the office, but then there were all these people in the middle that they weren't nursing home patients, but they were kind of debilitated and couldn't get to the office, and they really had no one to take care of them.
Right.
So you either, if you were able-bodied, you could get into the office. If you were really, unable to function, you're in a nursing home and you're cared for. But what happened to all those people in the center? They weren't getting care.
Right. Absolutely.
So what would happen is they would decline and then end up in a nursing home or in a hospital, and we're trying to prevent that.
Well, it has to be a great feeling professionally
And I
to
say
know that
we,
you
but it's
impact
really- it's
quality of
really
life.
Wendy, so I say we just because I'm part of the
Well, you make the
program, but-
referrals. That's okay. That's
No,
all right.
it's
No,
it's
don't direct the
job
program,
satisfaction
but,
at the end of the day is fantastic.
Yeah.
I mean, touching so many people's lives, making such an impact. They get to stay home. They get to be healthy. Most importantly, it's a wonderful feeling.
And just sitting there and forming a relationship with people in their home is great. And
like,
it is so
and
satisfying.
back to the fact that I don't have 15 minutes. I have an hour with these
Right.
patients, an hour
Yeah.
to really, dive in and see
Right.
what's going on.
Yeah,
So
that's great.
Yeah.
What's your caseload? How many patients do you follow currently, do you think?
I don't know how many patients I have.
Yeah.
But I see between 6 and 7 per day.
Wow. Full schedule.
Full schedule. Yep.
And
many
that's
times,
all around. You're driving to
Yes.
all these various locations.
Yep. So we have a scheduler, but I know the city of Fall River like the back of my hand and all, the surrounding communities. So I will look at my schedule and try to rearrange people. So I'm not ping-ponging back and
Right,
forth.
right, of
So you
course.
work more efficiently. So I see 6 or 7 patients per day, and then I often see patients on Saturdays.
Oh.
So overflow I see on Saturdays if needed.
How many
That's
miles do you
great.
put on your car a year?
It's actually not as bad as you would think. It's actually not that bad. When I was working in Dartmouth, I actually put more miles on my car. So I don't know, maybe 12,000 a year.
That's not bad.
No, it's not bad at
It's
all.
all around the city. so-
Yeah, it's not bad.
I'm just curious.
No, that's a legitimate question because when I first took the job, I was concerned about miles.
Yeah.
And then I'm actually leasing a car right now, and they said, how many miles? I'm like, oh, I'll be fine with that because I know I don't go over 12,000. So that's, yeah,
Oh, guess that works out well then.
a little side.
Wendy, in closing, is there any message you want to get out to anyone who may be listening to this podcast?
Sure. PrimaCARE is right here in the city of Fall River. You can visit the website, and if you have a family member or you are in need of a home visit, reach out to your primary care doctor, and we can set that up for you.
Yeah.
Absolutely.
That's great.
Great,
It's a great
thank
program.
you.
We're grateful for PrimaCARE for supporting it. And we're grateful to you, Wendy. And we offer a nursing home program too, which covers the nursing home patients, and maybe we'll talk about that at some point also.
Yeah.
But we're trying to take care of patients in all of their care settings, basically.
Right. In the nursing
That's what
home,
PrimaCARE's attempting to do.
the nursing home, we have a relationship with the nursing home that you're affiliated with in the city. And when somebody is going home, we get a message from the nurse practitioner saying this patient would benefit from a home care visit. Can you please follow? So right from the nursing home, they get a home visit, and if needed, we follow them through their recovery in the
It's
home.
great support.
Yeah, I mean,
Before we
there's
release
some
them
really
back.
great data that if a patient is seen within a certain amount of time after hospitalization, particularly with certain diagnoses, COPD exacerbation, pneumonia, heart failure, it reduces the hospitalization fairly dramatically. Well, some of those patients really can't get into the office because of their physical limitations, and sometimes it's just more of a scheduling issue with the offices
Yes.
too. They're just so busy.
Yeah.
So, Wendy can fill the gap for some of these patients, and we appreciate what
Do
you
you do you work closely, just because you said something, do you work closely too with any of the clinics from St. Anne's? Like, do they have a COPD clinic or a CHF clinic or anything like that?
The only clinic I work closely with is the Wound Care Center.
Oh, yeah,
At
that's
this
great.
point, yeah. The Wound Care
That's
Center,
nice.
they know me, I know them.
Yeah.
We go back and forth with orders.
Yeah.
Yeah.
Okay, great.
Well, I want to thank you. We're really thrilled that you were able to come.
Oh,
forward
thank you very much for
today
having
and
me.
Talk a little bit about the program. It's a great program. We appreciate the work that you do.
Thank you.
And I want to thank our sponsor again, Pecos Bank. Pecos Bank is right for all of your needs. Please visit them at pecosbank.com or call 508-678-7641. So thanks again for watching the 27th Degree with Chris and Nancy from 27 Degrees Consulting. And Wendy, thank you very much for talking about the PrimaCARE home care program. And if anyone has a loved one out there that you think would benefit, and they have a PrimaCARE physician as a primary, you can just contact that office and they can put a referral in.
Absolutely.
All right. Thanks everyone and have a great day.
Thank you.